Morning, everybody. Presenting on behalf of Medicine 2 Unit 2 by 3. Presenting 34-year-old gentleman, Mr. S. from Paschim Medinapur, West Bengal. These presenting complaints are from OPD. He's presented with fever for 4 months, dry cough for 4 months, joint pains for 4 months, alternating bowel habits for 3 months, and loss of weight and loss of appetite for 2 months. I've added some more presenting complaints here because this is the full presenting complaints when he was admitted in the ward. His additional complaints were episode of a severe abdomen pain and rash, skin rash 1 month back. He had erythematous non-painful skin rash over the palms, which resolved in 3 weeks' time. And he had class 1 NYHA shortness of breath. And he also had increased grade of fever and irrelevant talk for 1 day, for which he got admitted through ED. Coming to the history, the fever was low-grade intermittent with chills and night sweats, subsided with paracetamol. Dry cough was there for the past 4 months, but no history of seasonal exacerbation, no pleuritic chest pain, or no hemoptysis. The joint pains have been there for 4 months, symmetrical, large joint, axial, and peripheral. They were non-migratory type involving knees, ankles, trunk. They were episodic mainly during the fever attack, not associated with any swelling. Altered bowel habits been there for 3 months. Around 2 to 3 days a week, he passed loose stool with no blood or mucus, and on the remaining days, he was constipated. Loss of weight and appetite, it was significant, more than 10 kg. Unintentional loss of weight and loss of appetite over the past 2 months. And this additional complaints which we got during the admission was that episode of severe abdomen pain. He did not pass stool for a day, and he had 1 episode of vomiting. He came to ED and he was treated symptomatically and then sent back. He had this skin rash 1 month back. She complained of erythematous macula. It was painless over the palms, bilateral palms, and resolved in 3 weeks' time. He also had this ongoing class 1 NYHA shortness of breath. And just before admission, his complaint was increased grade of fever, high-grade fever with irrelevant talk for 1 day. He had high-grade fever with chills, 102 recorded with irrelevant speech. But there was no positive movements, deviation of mouth, deviation of the facial muscles, slurring of speech, jerky movements, frothing of saliva, head trauma, urinary or bladder incontinence. No history of drug or toxin exposure, no animal bite or exposure. There was no history suggestive of liver disease or kidney disease like jaundice, pedal edema, abdomen distension, decreased urine output. Other relevant history, there were no history of rash, red eye, oral or cutaneous ulcers, no alopecia, no skin hyperpigmentation, no binding of the skin, no frothy urine, no IV drug abuse history. It's not a smoker, not an alcohol consumer. A significant history was that he was known bicuspid aortic valve from 2008 onwards. He has through these 4 months, he has been given intermittent antibiotics elsewhere, but his symptoms did not subside, and so he has come to a CMC for further management. No significant family history was there. The examination findings, in the general examination, there was clubbing, there was small mobile level 3 cervical lymphadenopathy, palpable lymph nodes bilaterally. There was no palaictus or sinus or edema. Heart rate was, he was tachycardic at the time of admission. BP was normal, and respiratory rate mild tachypnea of 24. There was ejection systolic murmur at the first aortic area, and he was tachycardic. Respiratory system was normal. Showed there is a throb space was dull. Central nervous system examination at the time of admission. He was conscious but not oriented. He was speaking fluently. Comprehension was fair, but and this is just a disparity. And then he became anomic aphasia for some time, and then after that he became apraxic. Cranial nerve examination at the time initially were all normal. The motor examination observable with the best observable motor examination was also normal. The sensory examination was also normal. Whereas the cerebellar signs we could not assess as much. There was no meningeal signs. Musculoskeletal examination, there was no tender, swollen, or red joints. There was no masses or deformities. There was no abnormal skin findings as well. The end of clinical history and examination, there is history of prolonged fever. There is GI disturbances, dry cough, dyspnea, episodic joint pains, loss of weight and appetite with an episode of severe abdomen pain, episodic resolved skin rash. Currently has come with acute febrile encephalopathy. Examination significant findings. There is clubbing, small cervical lymphadenopathy, splenomegaly. There is ejection systolic murmur, and currently encephalopathy features were there. The clinical impression was that of a chronic disease with bouts of acute presentation involving multiple systems, and currently has come with acute meningoencephalopathy. Thank you. Moving on. The differential considered with this all the clinical features summed up. The chronic infections like tuberculosis, infective endocarditis, syphilis, brucellosis, milioid, histoplasma, HIV, chronic EBV, autoimmune diseases as well like IBD, vasculitis, rheumatoid, SLE, sarcoid, IgG4 stills, and malignancies, lymphoma, which present with prolonged fevers, colorectal carcinoma, lung, hepatocellular, renal, and as well as lymphoma as told before. Initial evaluation was the acute problem differentials considered infective acute meningoencephalitis or vascular causes or metabolic, which were unlikely to lower down the differentials. Initial evaluation showed anemia of 9.3 microcytic picture, leukocytosis with left shift 14,000 counts with 83%, and there was a mild hematuria at the time in the ED. Chest X-ray and ECG were normal. Electrolyte panel was normal. The MRI brain had shown acute ischemic infarcts involving multiple areas: left peri-Rolandic post-central gyrus region, ventromedial aspect of left thalamus, left frontoparietal deep white matter, and also few on the right side also were noted. The CSF analysis had shown a total counts of 21 with 51% neutrophils. CSF glucose was mild lower and the protein was normal. There was no growth in the CSF. There was the viral PCR was negative, expert was negative, pneumococcal antigen as well was negative. The further investigations in terms of inflammatory markers, CRP-SR were elevated with rheumatoid factor 205, whereas the other panels were negative. And coming to the infective workup, BBVS was negative, syphilis, brucella was negative, bone marrow was normal. Bone marrow is normal with the bone marrow cultures being sterile and expert negative. CT thorax abdomen was done, which had shown only moderate splenomegaly. So at this point in the differentials, we have went ahead to look for infective endocarditis. The transthoracic echo had shown a bicuspid aortic valve, but there were no vegetations found. There was mild AS, mild AR. The blood cultures, however, had shown the growth of alpha hemolytic streptococci, GPC in long chains. 3 of them were positive for this alpha hemolytic streptococcus. So we have pushed to do a transesophageal echo, which had then showed evidence of a vegetation. It was filamentous echogenic mobile structure at the anterior mitral leaflet was significantly large, 16 into 12 millimeters in size, prolapsing into LV. And the other features were as before in the transthoracic echo. So satisfying the modified Duke's criteria, it was very much evident of infective endocarditis. And but the presentation here was of a varied clinical features and with acute presentation of acute encephalopathy with a probable septic emboli. So few points I wanted to share here is that infective endocarditis, what varied features it can present is a table from Harrison's. This is in the descending order where we see fever, chills, anorexia, myalgias, arthralgias in the top, which all the patient had. As well as he had a heart murmur, he had arterial emboli, he had splenomegaly, he had clubbing, he had neurological manifestations in the end. In the lab investigations as well, he had anemia, he had leukocytosis, he had elevated C-reactive protein as well as rheumatoid factor. And here a point is that echo, there is transthoracic, there is transesophageal echo. This is an algorithm again from Harrison's, where it tells us when to do thoracic as well as when to do the esophageal echo. When we suspect an infective endocarditis, when a high initial patient risk is suspected, you can go straight away to do a transesophageal echo. The high initial patient risk is defined as a new regurgitation murmur, new ECG changes, congestive heart failure. You can go straight away with a transesophageal echo, whereas a low patient risk, we go with the transthoracic. And then which we have done on the left arm, which we have done. And then, but still, when there is a high suspicion that it still is infective endocarditis, we are not satisfied with the transthoracic echo. We have done a transesophageal, when it's a negative, we have done a transesophageal echo, which has come as positive. And then the treatment as follows. But there is again another arm here. When the transthoracic echo is positive for infective endocarditis, when there is high risk echo features, you still have to do a transesophageal echo for detection of complications. What are the high risk echo features is that large vegetations, valve insufficiency, paravalvular infections, and ventricular dysfunction, which need a very urgent surgical management. Transesophageal echo is recommended. And the point is that bicuspid aortic valve, which the patient had, is most common congenital heart disease, prevalence of 0.5 to 2%. And the patients who have a bicuspid aortic valve have a higher predisposition to develop IE, that is about 0.23%. When compared to normal population, normal population is 0.007. It is 30 times higher incidence in the people who have bicuspid aortic valve. This is a study published in from PGI Chandigarh. The patients all who were admitted between 2010 and 2020, 199 were diagnosed with modified Duke's criteria satisfactorily. They were included in this study. And in this study, we came to know that 45, that is 22%. This is a recent study from India, so which we can relate to us and understand. The 45% of them had congenital heart disease, out of which 18 were having bicuspid aortic valve. After the total 199, it comes to 9.04%. And the other congenital heart conditions were as follows. Also that the symptoms with which the patients had presented, and there was a varied duration of symptoms ranging from 3 days to 1 year. The median was 4 weeks. And another significant thing was that there was a shorter duration. Almost 1/4 of them had presented within 2 weeks of a duration of the symptoms. And the descending order of the symptoms were similar to which we have discussed earlier: fever, chills, shortness of breath, loss of appetite, loss of weight. And also we see in this study again that aortic valve, there is a higher percentage involvement in the native valve endocarditis. This is a total 199 of the total people, 111 were having native valve, out of which the most common is mitral, and the next comes the aortic. And then when we come to septic emboli, which this patient had, we see that 18% of the native valve endocarditis people had cerebral septic emboli at presentation. When compared to the other which is the intravenous drug use prosthetic valve endocarditis, is a higher percentage of people presenting with the cerebral septic emboli, whereas the others present with more of a pulmonary septic emboli. This being on the left side of the heart, this is higher predisposition to a cerebral emboli. So, in our patient diagnosis, a native valve infective endocarditis with septic embolic stroke with acute infarcts in different areas, and underlying bicuspid aortic valve. Management, it was a pansusceptible organism. We have given ceftriaxone, after which he improved symptomatically very well. Dental consult was taken for assessment and dental cleaning, and he was discharged for cardiology thoracic surgery for further plan of management. Take-home points: infective endocarditis with varied clinical features it presents. If you identify early, if septic embolus presentation is prevented, it has a better outcome, whereas if they present in septic embolus, the mortality is higher. And bicuspid aortic valve and its risk we have studied a bit. Thank you.
Thanks, Pranuth. Just moving on to, just before moving on to the questions, requesting the presenters to stick to time and keep it precise. And also, while listing the list of differentials, it would be reasonable to order them in the order of clinical consideration rather than listing them or classifying them as infective, autoimmune, malignancy, etc. Any questions? For want of time, we'll move on to the next presentation from Medicine 3, Dr. Brightlin on touch and die.